Hospital, Department of Surgery, University of the Witwatersrand, Johannesburg, South Africa.
And my compliments on pronouncing the name of my university absolutely accurately. Ladies and gentlemen, thank you very much again on behalf of your international visitors. It's been a real pleasure to be here. The gracious way you've looked after us has been amazing. And the ISS looks forward to a long and very fruitful relationship with the ESS. You did give me an hour and a half to talk on non-operative management of solid organ injury. So since I'm having to compress it down a little bit, we will see how we go. There's a lot of material to cover. One of the problems with non-operative management is nowadays it is more and more common not to operate than operate. Now, Egypt still has a lot of general surgeons, but those two-dimensional surgeons who only operate through a laparoscope, they have a different problem. The first recorded blunt organ injury which was operated on was in 1735. It was a splenectomy, and unfortunately the patient died. And until the late 19th century, about 100 years ago, all treatment of abdominal injury was non-operative, because if you operated, they died, and if they didn't operate, they probably died. So the odds said, don't operate. Between 50 and 90% of all injuries, no matter how they were achieved, died. 20th century, the death rate from abdominal injury, and we're now talking penetrating injury, was again around 80%. There were attempts at packing livers in 1908, Pringle maneuver. In the First World War, they packed livers to stop bleeding. The packing was left in for 10 days. The mortality was close to 100%. And at the time that the British were here, during the Second World War, if you packed a liver, it was a court-martial offense. If you were a surgeon in the British Army and you packed a liver, you were locked up because you were going to kill the patient, and they knew you would kill the patient. And it's only once the survival rates exceeded the rates for non-operative management that surgery became mandatory. During the second half of the 20th century, things changed again, particularly for penetrating injury. It was a time, for example, in South Africa, where there was a lot of violence in the late 1970s, 1980s, so much so in the way of penetrating stab, particularly, that there was not enough operating time. So patients with stabbed abdomens were put into the hospital to wait for their turn, and some of them actually got better. So it became very obvious that there were a number of patients who didn't need surgery. There are a few things you need to know. Firstly, plain films are extremely valuable, but the ideal ones in penetrating injury of the abdomen should be that the patient is sitting erect or lying on their side, because you are looking for free gas. The gold standard is high-resolution CT, but ultrasound will tell you about the presence of intra-abdominal fluid. Your big problem is two things. One, is there a problem? And two, do I know what to do with that problem? Now, with blunt injury, we've tended to be quite happy to watch these patients if they stay stable. We know that if you take the spleen out, around 0.5% of patients develop relatively lethal post-operative sepsis. That does mean that you have to take 200 spleens out. Anyone here taken 200 spleens out? I don't think anybody has, to get one case of sepsis. So the rate is actually quite small. The reality is, in the United Kingdom, in 2019, more children die because they bleed to death from their spleens than die from operation. So maybe the pendulum has gone too far. So what are the principles of when do we not have to operate in the abdominal cavity particularly? One, do we know there's an injury present? Examination is a problem. The pH of blood is 7.4. blood does not irritate the peritoneal cavity. You can have a couple of liters in the peritoneal cavity and you won't know that. Yeah, your cavity might be a little bit bigger than normal, but only your mother knows that. You need a patient who can tell you what's going on. So it's not great for small kids, and it's not great for the drug disorderly or the head injury. You have to have hemodynamic satisfactory level. Those of you who've done or come across ATLS will know that class 3 shock with a blood pressure below 90 is 2 liters of blood loss. Those patients don't do well with non-operative management. The treatment of bleeding is to stop the bleeding. So they have to have adequate hemodynamics. And then the other thing is you have to watch out, because if you've got a patient with a fractured femur and multiple fractured ribs, they will not tell you that their abdomen is sore, because it's not as sore as the other 2 bits. So you need all of those things. What's our problem in 2019? It's a very simple one. Oh, if it was me, I wouldn't want an operation. Oh, I'm your patient. I don't want an operation either. I normally do laparoscopic colectomies. I'm not really very happy in the abdomen. I'm a thyroid surgeon. Abdomen, I've heard of it. I'm a breast surgeon. I've never heard of the abdomen. When did you last open the abdomen? Oh, 2 years ago. If anything says, I don't want to operate, more and more surgeons now are very, very uncomfortable. There's the patient, the surgeon is the football player, and that patient, or maybe the surgeon, I don't know who is more out of control. The other problem with non-operative management is that you've got to be very good at watching. That kidney is not actually watching what he should be watching, and that lion is very carefully watching what he should be watching. The end result is that we can miss an awful lot of injuries if we don't know what we're doing. And since we don't see that many in most surgical practices, we don't see that many, so we don't actually know what we're doing. There are some slides with quite a lot of print on them. I'm sorry about that. But the evidence base is now becoming quite good and quite clear as to what can we do and what can we not do. Right. First thing, the rate of non-therapeutic laparotomies after penetrating should be reduced. It should never be at the expense of a diagnosis. So if you have got penetrating injury and you are insecure, you need to operate. A friend of mine once turned around and said, do you know that a negative laparotomy is far better than a positive post-mortem? Think about it. If you're not sure, a negative laparotomy is far better than picking up the pieces later. If, however, the patients are hemodynamically stable, no signs of peritonitis, and no free blood or fluid in their abdomen, then a routine laparotomy is not indicated. And you are in better shape than the Americans, you'll be pleased to know. The Americans, particularly some parts of America, have a minor weight problem, as you well know. And obesity is the biggest problem in the United States at the moment. Now, one of the interesting things about that is that as you get fatter, and we're talking 200 kilo BMI 50 to 60 people, the abdominal cavity itself is compressed into a smaller size, and you have up to 30 centimeters of fat on both sides of your abdomen. If you get shot, it doesn't even go through the abdominal cavity, and the Americans have this great term of, it's called urban armor. I'm not suggesting we all get fat to avoid getting shot in important places. So let's look at individual organ systems, and we'll stick with blunt for a moment, because blunt you will see on the CT scan. If the patient is unstable, the patient is actively bleeding, that patient needs factor 14, it needs a surgeon's finger. It does not need a CT scan, which was, after all, designed by Walt Disney and called the donut of death. Because if you put an unstable patient into a CT scanner, which is at 19 degrees anyway, you will have more dead patients than you will save. So you need to be relatively hemodynamically good, but blunt injuries you can look at on the CT. If they have shock, high ISS, and other injuries, you do not want to do non-operative management. So where you've got high-grade injuries, looking at this patient, you can see that around the spleen there's a huge amount of blood, and intra-abdominally there is a huge amount of blood. This patient's blood pressure was 60 systolic. This patient needed factor 14. This patient needed the surgeon's finger. Here is a major injury to the liver with blood around the liver, but actually the rest of it is not too bad. Maybe this is one that we worthwhile angioembolizing. And when you do angioembolizing, you see the coil in place, same patient. Now it stopped bleeding. So where you've got a patient with single organ injury and a good close by radiology or angioembolization service, whether it's vascular service or whether it's radiology, go for it. What about spleens? We know that we used to take out not enough spleens, then we took out too many, and now we don't take out any. But the problem again is if the patient is bleeding, and particularly if you've got CT scan evidence, those patients who are hemodynamically unstable need the spleen taking out. You have to take out 200 spleens for one case of OPSI. So unstable, need a splenectomy. Stable patients, angioembolization is the answer. Pancreas, I'm beginning to sound like I don't need to give the rest of this lecture, because realistically the first bullet point there applies to every single organ in the entire abdominal cavity. If they are not stable, if they are obviously bleeding, if you can't do it, find somebody who can, or find yourself a good mortician who will not blame you when the patient dies, because that is what is going to happen. On the other hand, if you get there in a stable patient, you can deal with it. Problem with the pancreas is you've got the duct to the pancreas as well, and pancreatic juice is very, very corrosive. So where you've got pancreatic duct injury, you may not see it originally in the CT scan. So when you've got a patient who is stable with a pancreatic injury and possible injury to the duct, you probably should need to look at it firstly using a portal venous scan that will tell you if you think that the duct is transected in the middle of the body or to the right of that, that patient as a minimum needs drainage and probably needs a distal pancreatectomy. If you have availability of it, MR cholangiopancreatography can be quite useful. But again, your patient has to be well enough to earn the right for it. That bottom line is important. Only if the duct is not injured is it safe for a grade 1 or grade 2, because if there is pancreatic leakage, you can do a percutaneous drainage. If you think the duct is damaged, pancreatic injury has a very high mortality, not because of the injury, but because of the pancreatic fluid that comes out of that duct. And you have no choice but to get there sooner rather than later. The American Association for the Surgery of Trauma has grading systems for almost every single injury, from the testis up to the ear, to the nose, to the chest, to the heart, to everything. In principle, the grading system is based on anatomical injury, but in fact it helps with surgery. If you go to AAST.org, American Association for the Surgery of Trauma, those grading systems are all there, there are 39 of them. Grade 1 essentially says bruising, and the kidneys are just an example, bruising but no laceration. Grade 2 says laceration but not involving a vital structure, as you see on the second frame down on the right of your picture. Grade 4 to 5 means catastrophic damage to the organ, which will probably result in the removal of part or all of the organ. An intra-organ Hiroshima. All grade 4 and grade 5 injuries need surgery, and they need it soon. Grade 3 is where you say, well, maybe depends what I've got. So because this is a very easy organ scaling system for every single, and it's available on the net and on your phone and everything else, it's available for every single injury. You have got the ability to choose what you should and shouldn't be operating on. So kidneys, ongoing instability, needs surgery. Otherwise, not very much. Pelvis, the treatment of bleeding is to stop the bleeding. Compression is your first bit. Angioembolization is your second choice. And finally, surgical open is the third choice. We mentioned yesterday, but I will mention again, particularly with pelvic injuries, balloon occlusion of just above the bifurcation, which closes off both iliacs, will temporize quite well. Do not use it in liver injuries. With kids, hemodynamic status rather than the grade of injury guides care. If the kid is unstable, they're going to collapse and die on you quite soon, as will older patients. So non-operative management is for the best fit. And your patient, if they're old, may be less fit, but may not survive the hemodynamic insult of bleeding to death. They just don't have the reserves. So, patients who are unstable should have laparotomy. But it is not indicated in the stable patient without peritonitis. Abdominal CT is your investigation of choice. Angiography with embolization, if you see it on CT, is your intervention of choice. And hepatic injury should only be considered in an environment which allows you to do something if you have to. And no recommendations are available on any of those 7 things. How often do you do the hemoglobin, abdominal exam, intensity, nothing else. So the jury is still out on a lot of things. Where are the pitfalls? Well, we'll use aviation. Aviation says error is normal. Don't blame error, try and prevent it. Do not, and this, unfortunately, this pilot landed in a snowbank and the snow kept his doors closed and he froze to death. Do not allow your patient to become hypothermic. Do not drown them in crystalloid. This is a aircraft that landed just short of the runway in Uganda. Too much fluid, bad idea. And failing to look at the whole picture is also a bad idea. Most of you are looking at that. Did you all pick up the missile going on the bottom right-hand corner, which is why that crewman is running? Look at the whole picture, because if you don't look at the whole picture of the patient you're treating, you will miss parts of the picture. With proper patient selection, proper injury grading based on AAST and the CT scan, use of angioembolization and ERCP in the patients who are safe enough to have it, your outcomes will be very good. Fear of operating is not an indication for not operating, and non-operative management should only be used if you have the ability to watch that patient. Thank you very much.
Thank you very much. I think this state-of-art lecture, if any one important question.
I have a comment on the question. The comment is on the incidence of post-splenectomy septicemia is 0.5, yes, but in adults. But the incidence in children may reach up to 5%. So we have to take care. Are you agree with me with that?
I agree with you partly. Unfortunately, the microphone is a little faulty, so I picked up about half your statement.
Okay. The question is that organ trauma scale is already in the advanced trauma life support, or you are using another scale system?
No, it's not so much in the advanced trauma life support, because that is in the initial and pre-hospital, often before investigation. Yeah. It is in almost all more advanced operative surgery courses, yes.
Thank you very much.